Dr. Shiv Kumar will be speaking on closure of the paravalvular leaks.
In this next 15 minutes, probably we will go through certain concepts about paravalvular leak device closures. We know about the mythological various avatars, and we know that depending on the situation, God is going to come in an appropriate avatar. I will come to what is the relevance to this picture later. In general, whenever there is a paravalvular leak, and then the cardiologist goes and tells the surgeon that I am trying to fix it, the surgeons are very skeptic. I accept that the patient is very pale, that means anemic, jaundiced, edematous in heart failure, dyspneic. He may have secondary atrial fibrillation, but still, you see, he is alive. If you do something on that valve and the valve closes off, he will be dead. And so, even if there is a paravalvular leak and the patient is in heart failure, try to manage medically and don't try to screw up, because it's going to be difficult to undo some of the harms that we may create in the cath lab. So actually this is an editorial written by Dr. Carlos Ruiz, who is an expert from New York, and he says still there is a long way to go. So if you see, device closure of paravalvular leak is very useful if you are successful. However, it's extremely risky if you are unsuccessful and create a harm to the valve. Is there a definite advantage in a catheter-based therapy? True, because the tissues in the paravalvular leak area are fibrosed and calcified, and so even if the surgeon tries to take sutures again and again in that area, they are going to give up, because the region of the annulus is diseased. And obviously, whenever we do a redo surgery, there is an attendant morbidity. However, we need to understand it is not like a ASD or VSD closure. It's an unusual procedure, and it needs at least some amount of operator experience. And all the devices that we are using are off-label uses. If suppose the paravalvular leak extends for more than 20% of the circumference of the annulus, obviously it's not going to work. And you can have different shapes of the paravalvular leak. It may be crescentic, it may be serpiginous. So how I will approach this topic? We will see how clinically significant is a given paravalvular leak, how to measure the paravalvular leak, how to image a paravalvular leak, and when to think that surgery is better than a catheter-based closure. What are the new imaging modalities? Should we guide our procedure by fluoroscopy or by imaging? Whether we should cross the paravalvular leak antegradely or retrogradely, and then coming to newer methods like hybrid approaches. How clinically significant is a paravalvular leak? Use your conventional wisdom. If the patient is in heart failure, he has a hyperdynamic rocking precardium, significant cardiomegaly, anemia, hemolytic jaundice, obviously he needs something to be done. By echocardiogram, if the LV dimensions are large, if the paravalvular leak jet width or the jet area is large, in a mitral paravalvular leak, if there is a lot of flow reversal in the pulmonary veins, in the aortic paravalvular leak, if there is a lot of flow reversal in the descending thoracic aorta, early closure of the mitral valve, which is a sign of elevated end-diastolic pressure, again in an aortic paravalvular leak, the width of the vena contracta, all these are simple conventional methods of assessing the significance of a leak. So for example, if you are getting a transmitral gradient, you see the pictures, it is around 2.5 meters per second. That means somewhere around 25 millimeters of mercury is the transmitral gradient. That means there is a tremendous amount of antegrade flow in the mitral valve contributed by the normal stroke volume along with the regurgitant volume. And if you are having a left ventricle which is 82 millimeters in diastole and 66 millimeter in systole, we need not be very struggling to understand that this is a dilated ventricle. How to measure a paravalvular leak? You can do two types of measurements. One is to identify the regurgitant volume and regurgitant orifice area, something like what you do for a mitral or aortic regurgitation, which can be done by a volumetric method or following PISA, or just assessing the vena contracta width. If it is more than around 6 millimeters, any paravalvular leak is of quite significant, very significant. Quantify the size of the leak to plan the device. That is a crucial step. 2D echo measurements are fallacious because all the surrounding structures are metals. So you have on one side tissues, another side metal, and so you are not going to be very accurate on 2D measurements. However, color jet measurements are more reliable and take in two different dimensions because all the holes are not circular. They may be oval, they may be crescentic, and of course 3D echo will have marked improved accuracy. This is what is a 2D assessment, 2D echo. You see here, you are able to expose a paravalvar leak here. On this side is the metallic valve, on this side is the mitral annulus. And so you wait for the jet and catch the paravalvar leak, freeze the frame and try to make a color width assessment. On a parasternal long axis view, this is an aortic paravalvar leak and you can freeze the frame where there is diastole and just measure this vena contracta here. In a short axis view, you can take the color acquisition, freeze the frame where there is, what I am pointing is the paravalvar leak, freeze it, color suppress and then take the measurement. So this is also reasonably accurate. Transesophageal echocardiogram is going to be helpful because it is going to identify the number of leaks. It's going to identify the jet width of each one of the leak, shape, orientation, the direction of the jet, and also in mechanical valves, identify the leaflet mobility, whether already there is an impairment of any of the leaflet mobility. Once you identify on transesophageal echo, you magnify the screen as big as possible so that you try to get a most accurate measurement. Sizing in two different planes. You take on two orthogonal planes on a transesophageal echo. If your first plane is going through around 20 to 30 degree, take another view through 120 degree or so. So that in two orthogonal views, you cut the color jet and then measure the color jet. 3D transesophageal echocardiogram, of course, is a great, it gives tremendous anatomical information because it gives the precise location. This is a mitral bioprosthesis with a paravalvar leak. The orientation and its relation to the adjacent structures can be shown very well. This is the mitral paravalvar leak with the mitral bioprosthesis with the paravalvar leak, and you can see that this is the left atrial appendage, this is the aorta, and so you can precisely locate it anterior to the left atrial appendage and immediately posterior to the aortomitral curtain. So this sort of anatomical information is going to be achieved by going for a 3D transesophageal echocardiogram. Similarly, if there are multiple leaks, it's going to be identified only by 3D TE. You see here, this is another mitral prosthesis. Contrary to the previous patient, this is the left atrial appendage. You have the paravalvar leak all along the posterior area. You can see the thin sutures that are running through, and there are 1, 2, 3 and 4 leaks. And so it is going to be a sort of a long crescent with some 4 sutures running in between. This sort of anatomic information you will be never getting on a conventional 2D echocardiogram. And so in today's practice, I would strongly recommend that a paravalvar leak should be attempted only when we have 3D echo. So when we freeze that frame, you can see that there is 1, 2, third one here and a 4th long one here. How to image a paravalvar leak? Conventionally, by fluoroscopy, we throw contrast in the left ventricle in a mitral paravalvar leak or in the aortic root in an aortic paravalvar leak and try to find out where is the jet. However, we need to understand that there are certain valves where the disc will be radiolucent. For example, TTK Chitra valve, which is made in our own country, has got a high density polymer disc which is radiolucent. So you will not be able to see this disc. And similarly, in certain forms of St. Jude valve, you will not be able to see the ring. You will be seeing only the discs. This is a Chitra valve. Actually, the mitral process is a Chitra valve, and you can see that the discs are not seen. So we need to understand that each and every valve, because not all the valves are going to have a perfect radio-opaque ring and a radio-opaque disc. Sometimes the entire valve can be fluorolucent. That means not able to see at all. You see, this is a St. Jude bioprosthetic valve. You can see a thin line here. That line is the total valvar prosthesis. You will not be able to see any metallic structure at all. And so in these cases, if you have to go and cross the valve and be very sure that you are only outside the valve, you need to have a good echocardiographic assessment. So fluoroscopy is going to have some limitations. It used to be one of the very favored method about 10 years before, when most of the valves were radio opaque. However, the newer valves are all, most of them are radiolucent, and so if you are going to be coming across a St. Jude bioprosthesis, you are going to be totally be relying only on echo. In fluoroscopic guidance, once you identify that there is a paravalvar leak, then subsequently you need to use the same fluoroscopic frame and keep crossing with the wire and with the catheter and ensure that the valve discs are not getting affected at all. The present day image guidance is primarily by 3D echo. Here you can see an en-face view of the aortic bileaflet prosthesis, and at 3 o'clock position there is a paravalvar leak through which you are advancing the guide wire, and whenever there are more than one leak, obviously you need definitely a 3D echo guidance. So this is a posterior paravalvar leak which is being crossed by a wire, and a lateral paravalvar leak crossed by another wire. We can also understand that some of them are very, very crescentic, and it helps us to understand the anatomy very well. Sometimes it also gives an additional information about, is it going to be feasible at all. This is a 23 millimeter aortic mechanical prosthesis and a 20 millimeter long paravalvar leak. So when the valvar paravalvar leak is very, very large, it will not be possible to achieve with a transcatheter closure, and so a 3D echo will give some sort of a insight into our understanding. And also, once we understand, we can plan the devices, what we have to do. If it is a long oval defect, then probably 2 devices may have to be implanted in the same area, or there are dedicated devices now which has come into the market, which is the Amplatzer vascular plug 3, which is a sort of a oval device. Now, with this information, we have to understand that there are quite a lot of valves that are available, and we have to understand the specific valve that you are dealing with, and before the procedure, talk to the surgeon or Google in the net about that particular valve and understand which portion is radio opaque, which portion is radiolucent. The sizing will be primarily today based on 3D transesophageal echocardiogram. You can use, if you don't have those facilities, a balloon sizing, but don't just balloon size in one single plane. This is a balloon sizing done for a Jock-Shiley prosthesis of a mitral paravalvular leak through a transeptal puncture. However, you need to do it in 2 orthogonal planes and then measure what is the diameter, so that this is going to give you an insight about how oval or how crescentic the device is going to be. And as I told you earlier, today the sizing is primarily by 3D transesophageal. When to think about surgery, you have to closely discuss with the surgeon. It is after all a surgeon's baby, and their view should be respected. And if it is a dehiscent, loosely hanging prosthesis like this, in a rocking prosthesis, obviously we should not try to venture, because if we put a rigid sheath, we may avulse the valve, and the valve may just get embolized from the whole mitral apparatus. Newer imaging techniques, I am not going to talk much because it's not still available in our country. What is this antegrade versus retrograde technique? If let us imagine that this is the mitral prosthesis, this is a Jock-Shiley, and if you are going to cross from the left atrium into the left ventricle after a transeptal puncture, that is called antegrade crossing of the valve. If you are putting a catheter from the left ventricle and going backwards, then that is called retrograde technique. Similarly, for an aortic paravalvar leak, if you are going to enter from above downwards, that means aorta to the left ventricle, it is retrograde, and if you are going to go from LV to aorta, that is called antegrade. Why is mitral retrograde always better? The reason is, in most of the patients with a mitral paravalvar leak, the left atrium will be aneurysmally dilated to about 10 centimeters. And in a 10 centimeter left atria, to try to identify a 6 millimeter paravalvar leak and enter into it is going to be very difficult. On the contrary, if you go from the left ventricle, the wire will hit the left ventricular walls, and the wire will be deflected along the annulus, and it will be crossing through the paravalvar leak. So it's always easy to go retrograde on mitral. Obviously, aortics will always be retrograde. The moment you have crossed it, advance the catheter, put a J wire and snare it through the transeptal sheath which I have already placed, and then close it with a device. If you are going to cross antegradely, there are certain directable catheters like Judkins right. The previous speaker was talking about Amplatz left for trying to hook and enter the coronary sinus. These are all directable catheters which you can try to direct towards the paravalvar leak. There are deflectable guide wires made by Cook. There are deflectable sheets that are available from the Senjure or Lifetech, which is called the Fustar system. Now, I told you earlier, it is easy to cross retrograde in a mitral valve because the leak is far smaller, fairly bigger compared to the left ventricle. However, it is difficult in an antegrade closure. This is an aortic paravalvar leak, crossed retrogradely, and you put in the sheath and then put in the device. So, this is the device in position. Which device is ideal? All the devices are off-label, and so the available devices that are commonly used are ADO1, the Amplatzer vascular plug 2 and 3, and the muscular VSD device. Amplatzer vascular plug is a newer entry. If there are multiple defects, you may have to use multiple devices. So this is 2 wires being crossed, 2 devices in place. You can see one on the 9 o'clock and one on the 6 o'clock position. And if there are multiple adjacent defects, I showed you that picture where there are 4 defects, so you may have to use parallel plugs. So these are 3 plugs all around to close this sort of series of defects. And another 1 minute it will be over. Yeah. If you have to pass around 3 or 4 devices across the mitral valve, that does not mean you have to puncture the atria transeptally 4 or 5 times. You just make a single transeptal puncture, put in an 8-French sheath and advance as many wires as you want. You can put 3 or 4 and then try to, these are 3 superstiff wires that has gone through the transeptal puncture into the left atria, and through that 3 sheets are taken. You can see 1, 2 and 3, and 3 plugs are being put in. The recent trends are hybrid surgery, which means you take a puncture from the left ventricle, go in, cross the paravalvar leak under with a straight wire and catch it from the transeptal sheath, and then you achieve the paravalvar leak closure. This is a paravalvar leak in a patient who also has got an aortic mechanical valve. That means you cannot cross the aortic valve to enter into the left ventricle. So in this patient, you have to go only by transapical. And you can also notice the PISA method of how to assess the regurgitant volume. I was talking in the, and once you have made a puncture in the apex, you cross the paravalvar leak and get it snared through the transeptal sheath, and the moment you have snared it, then advance the sheath into the paravalvar leak and close it with a device. This is the device final position. If you are going by a percutaneous route, you can even close the left ventricular puncture with an Amplatzer duct occluder 1 device and come out. So while in the earlier 2000s, we were using primarily only 1 arrow, that means fluoroscopy alone. Then later we started using 2-3 gadgets, one, that means echocardiogram, 3D echo, multiple gadgets. And today we have too many options. We have a surgeon, we have a surgical assistant, we have our own assistants, and we can do everything in a hybrid manner rather than trying to do everything in the cath lab only with fluoroscopy. So the key messages: understand the anatomy, use 3D echo, understand the valve, you can Google about the particular valve, sit with your surgeon and decide the best strategy, choose the device, the type, the size, the number, choose the approach, whether you are going to go antegrade or retrograde, and hybrid team approach is very, very useful. And newer technologies like echo integration, that's called echo navigation. While you are crossing the paravalvar leak, you will be able to see 3D en face of the valve over the fluoroscopic image. Philips has got it, and CT integration is also there. Thank you.